MRD was born in ALL. It was born in pediatric ALL. And also the mean to detect MRD, there are three ways to detect MRD, multi-fax, and PCR and next generation sequencing. And the most sensitive way to detect MRD is by next generation sequencing. And if you have an MRD of 10 to the minus 6, you are cured. So by fax or flow cytometry, multiparameter flow cytometry, the effects or the significance of MRD is the same if you do it by multiparametric flow cytometry or by PCR or by next generation sequencing. And it's also the same or always prognostic factor if you do it after induction or after consolidation or after maintenance. So again, first of all, the decision to go or not to go to transplant in ALL is MRD based. If you are standard risk AML and ALL, and MRD negative, you don't go to transplant. If you are standard risk and you go to transplant regardless of the MRD, if you only high risk by cytogenetic or genetic factor. And then if you are Philadelphia positive, then there is a question if you are go to transplant, but according to the EBMT recommendation, even if you are MRD negative and Philadelphia positive, you go for transplantation. But this is not, this is a very tough or hot debate this day. And again, after transplantation, you have to give maintenance therapy if you're MRD positive for transplant because of the high relapse rate and the reduction in leukemia-free survival and overall survival. But if you are MRD negative post-transplant, then you can either monitor the patient and give preemptive therapy, or you can decide if it's high risk ALL to give prophylactic therapy. So this is for the transplant, but in ALL we have now monoclonal antibodies, the Blinatumomab, and in the blood study it was shown that you can convert a patient from MRD positivity to negativity pre-transplant, and this is extremely important. So if you are now this day MRD positive pre-transplant, you should get 2 to 4 courses of Blinatumomab in order to convert you to MRD negativity, and then go to transplant when you are MRD negative. And also we have the CAR T cells, which you can give to patients that don't undergo transplant or before transplant, and there are data that MRD is also predicting the outcome of transplantation after CAR T cells. So in ALL, MRD was this was the first leukemia to be shown the importance of MRD, and it dictates the paradigm of treatment of ALL today.